This chapter is pretty easy, not very lengthy in the textbook. What we're doing in the textbook now is we are getting into part two of the text, which is going to discuss population health. Chapter 5, of course, is called population health, and I want you to pay attention to two. I want you to pay attention to two population health models that look to explain um, why a certain population within the U.S. At a certain um, destination or in a certain region of the U.S., population health looks to explain why that group is either healthy and the factors that they have that keep them healthy, or why they're unhealthy and factors that make them unhealthy. So I want you to pay attention to two models of population health, and that's called the medical model and also obviously the population health model. And so that's what we're going to talk really, what we're going to focus in on with this lecture on chapter 5. So the population health model looks to explain where there's systematic differences in health among different population groups. So for example, what is the difference between um, the Northeast, right, and why they're in the Northeast in the U.S. and why they're healthier than population groups in the South, and where those groups in the South tend to be more unhealthy, tend to have more chronic disease, and more higher prevalence of obesity versus in the Northeast. Okay, so the population health model looks to explain those differences. Um, so in the U.S., we know that our life expectancy has gone up tremendously over the past 100 years. Okay, but over the past 30 years, it's really sort of leveled off a little bit. And the reason why that is I think we've talked about this in class before. Um, is if you're wealthy and if you have money, if you have private health insurance, you tend to live longer versus if you don't have health insurance, if you have a low paying job, a minimum wage job, if you make federal poverty line income, your lifespan tends to be much less than 78, 80 years. Actually, it tends to be in about mid 50s, mid 60s. And so the poor and the sickest in this country die, their life expectancy is much lower than if you have health insurance and if you bring in 300 to 600% of the federal poverty line as a household. You tend to live longer. You tend to live into your 80s and into your 90s. And so the population health model looks to explain, um, um, looks at factors between those two subpopulations. And this graph right here, that's what I want you to focus in on for the population health model. And so it really sort of, this right here, this graph encompasses the entire health model. And so it looks at somebody's, right here on the inner circle, your individual traits, what you're born with, your age, sex, race, biological factors, white, Hispanic, uh, black, uh, Asian, no matter what your race may be, it tends to look at all these innate factors, and it looks at somebody's health and chronic disease risk as uh, per somebody's age, again, sex, race, and biological factors. And then moving outward, it looks at all of those chronic disease factors on somebody as it relates to somebody's individual behavior, social, family, community networks, living conditions, work conditions, and just general health environment and where you live. Okay, state national policies, local government, et cetera, et cetera. And then it looks at those different, what's called determinants of health, right? That's what all these circles represent, are different determinants of health. And it looks at those determinants of health over somebody's life cycle and correlates that back to chronic disease. The medical model, which is the second model that I want you to focus in on, looks at something completely different. Whereas this right here, your determinants of health, your population model, this tends to be a little bit more proactive and preventative in nature, where it looks at large populations and large numbers of people, right? An entire race or an entire age, 35 to 44, female, white, and what their individual behaviors are across different socioeconomic status, and then how that affects determinants of health, right? So it looks at things on a larger scale versus the medical model looks at health, well-being, or sickness and sick being. It looks at it on an individual level. This is basically how we treat people in the United States healthcare system. It's reactionary, meaning that this model right here looks to link specific factors with a specific disease state. If somebody is already sick and has lung cancer, well, what factors caused lung cancer? And then with the medical model, what it does is it looks for that, what the book refers to as a silver bullet, to be able to kill that illness. Is there a medication that we can give in order to stop a determinant of health in order to cure the disease? Okay, if you're sick and you have strep throat, you go to the doctor. The medical model, what it does is it looks at, okay, well, what is causing strep throat? Let's give you an antibiotic to knock it out. Okay, or what we can look at right now, what is causing such a huge increase in the healthcare spending is obesity and obesity trends in the United States. And so it's no big secret that obesity is growing at an epidemic rate in the United States. Just look at obesity prevalence 30 years ago and look at what it is today, and it is just skyrocketing. And the amount of money that is spent to treat somebody who is obese or to treat groups of people that are obese, okay, it's a lot of money being spent with no return on that investment, because the detriments of health and then obesity, the negative effects that come with being obese, are most of the time not cured with the medical model. So if we look at obesity, for example, and then we go back to the population health model. This model right here is we study, all right, well, what are the factors that link somebody to obesity? Does age, sex, race, or any other biological factors, does any of that affect or predispose somebody to obesity later in life? Are individual behaviors linked to obesity? And of course, we know that especially some of the folks that may be majoring in nutrition. Okay, we know that individual behaviors such as diet, such as inactivity, right, sedentary lifestyles, we know that those two right there impact obesity rates. Okay, so the population health model would look at, okay, well, we know diet and inactivity levels contribute to obesity. So what can we do in order to make people's to make populations' diets better? And then also, what can we do to increase activity level for populations? Okay, so for example, you can look at some population health initiatives such as the Let's Move program from First Lady Michelle Obama, who goes into grammar schools and try to prevent childhood obesity in inner cities with the Let's Move initiative, right? There's public health grants that schools can apply for to get some funding to be able to buy phys ed equipment, or to bring in extra teachers or after school programs to be able to get kids to move, in order to fight inactivity, because a lot of these kids, they will go home, they do not live in safe environments, they have to stay inside because they live in high crime areas and they can't go outside into public parks. Okay, and we'll talk about that more in chapter 6, and we'll bring out a lot of Jacksonville examples, especially with the inner city, the north side and the west side, right in the urban core of Jacksonville, and why that right there is hands down. There's more chronic disease and detriments of health in the urban core in zone 1, what's called, than any other zone in Jacksonville or any other population in Jacksonville. So the population health model looks at these different determinants of health and tries to see what can we do in order to make exercise more available, or what can we do to make healthy foods more available to those people that don't have it. Okay, versus the medical model. Again, we're talking about obesity. The medical model would be you are say 45 or 55, you have a body mass index or a BMI of say 40 or 45, which is morbidly obese, and all the negative health effects that come along with that. So you go to your doctor, and the medical model would be, well, what is the specific link that is that a person has that is linking them to all these negative to all the negative health effects that they have, and why they're going to the doctor all the time. Well, it would be obesity. So the silver bullet for obesity in the medical model would be something like, okay, is there a pill we can give somebody, or the gastric bypass surgery? Okay, so to treat the individual episode instead of looking at big picture of taking care of populations and preventing the disease from ever presenting itself within that population. So, between the two, the medical model and the population health model, which one is more prevalent in the United States healthcare system? Well, it's the medical model. Okay, and in chapter 6, and I just talked about all the stuff. And in chapter 6, what we'll do is we'll talk, you'll see that we spend less than 5% of our healthcare spending, less than 5% is dedicated to population health, prevention, right, of chronic disease. It, what we spend money on is all trying to treat disease, and we know that all our money, I mean, we know over the past 30 years with chronic disease on the rise and all the money that we're spending in our healthcare system on the rise, the model that we're using right now, the medical model, just isn't working. Okay. Population health also tries to look at socioeconomic factors. Okay, and this is a graph right here that just shows level of education attained, right, with the different colored graphs. And then the different bars that are broken out here is race or ethnicity. Okay, so Black, non-Hispanic Americans that drop out of high school or have less than a high school graduate education, 73% reported having a less than very good health status. Okay, according to the Robert Wood Johnson Foundation, this study that was done in 2009. Okay. And then if you compare that to white non-Hispanic, okay, who achieve less than high school graduation, it's right about the same. It's 70%. So 73%, 70% reported reported being in poor health. Okay, between the ages of 25 and 74. And then vice versa of that, contrary to that, if you look at college graduates, right, there's a big difference between those that reported being in poor health and those that reported being in good health. Right, if you look at just Asian Americans or Hispanics, those that graduate college, 40% reported being in not very good health. Right, and so on average, it looks like it's about maybe about 36% of college graduates from the age of 25 to 74 report being in report being in less than very good health, right? Versus those that drop out of high school across all ethnicities, looks like it's about maybe 73% would be the average of those between the age of 75 or 25 and 74. So again, education has a lot to do with um, population health and prevalence of chronic disease. Which makes sense because if you're a college graduate, you make more money. Say you make 500 to 600% of the federal poverty line. You have money to spend. You're more educated, which means you probably have more time to be able to engage in physical activity during the day. You have more money to be able to buy fresh fruits and vegetables, to be able to purchase a house that's in a good location, that has a grocery store within a close proximity. And odds are you have private health insurance, right? Versus if you're a high school dropout or if you're just a high school graduate, right? You report being in poor health because the level of income is lower, right? You're at maybe 100 to 175% of the federal poverty line. You work for minimum to a little bit more than minimum wage. You work for an employer that does not give you or that does not offer health insurance. If they do, it's not affordable to you because you make a very low income, right? Your house would be in a lower socioeconomic status neighborhood where it's very common in those neighborhoods to have food deserts, right? There's no Publix or Winn-Dixie within a convenient location. And so the easiest attainable food for those neighborhoods is either at like a gas station, corner store, or fast food, right? And because you don't make a lot of money, you probably do not have private health insurance. So either go without health insurance or you have Medicaid, and there's a huge health disparity or quality disparity, quality of care disparity between Medicaid and those with private insurance. And so therefore the detriment of health and chronic disease is much higher in those folks, which makes sense. This right here is just showing, well, what are the leading behavioral determinants of health in the United States? And right here, 70% of all deaths in the US are due to behavioral choices, right? Unrelated to medical care, but 70% of all deaths in the US in 2009 were related to poor behavioral choices, such as smoking, physical inactivity, substance abuse, risky sexual behavior, and then diet. Bang, those five right there were linked to 70% of all deaths in the United States. And so from a population health standpoint, right, we would have population health programs in place to be able to impact smoking, right, obesity, physical inactivity, substance abuse. So for example, I already talked about the Let's Move campaign to combat childhood obesity. And one of the popular things you see right now on TV and in a lot of social media campaigns, because 70% because a lot of deaths are related to smoking, you see a lot of anti-smoking campaigns, right? The ones on TV to where you have the guy who has to cover his stoma when he shaves, when he mows the lawn, or you just go to YouTube and you can punch in anti-smoking ads, right? It's much different than um, television ads of the 40s and 50s when you had doctors on TV that were promoting a certain brand of cigarettes. Okay, much different because now we're paying for it literally and figuratively. Us as a society, we're paying for it with all the high costs of medical care to be able to take care of chronic disease related to smoking, such as cancers, chronic obstructive pulmonary disease, right? COPD, emphysema. Okay. But that right there, those are the five leading behavioral factors for death in the United States. This just further looks at, you can go back and look at this in the book and then also in here. This just further looks at healthy behaviors um, of folks that graduate college and those that don't graduate college. So the more educated somebody is, the better healthy behaviors they have. The book also discusses sort of regional locations in the United States and along with quality of care, right? Where you live matters. And the book talks about like different communities in South Dakota that are right next to each other, where one community or one county experiences a 66.6 years of life expectancy compared to literally the county right next door is at 81.3 life expectancy, and that's a big difference. South Dakota and Iowa it was. And so if you look at, let's just look at, no, sorry, it was in South Dakota, but it gives another example of an Iowa. It gives another Iowa example in the textbook. But if you just look at Jacksonville, for example, life expectancy in Jacksonville, say Duval County, compared to life expectancy of St. Johns County, right? You have the urban core, downtown, health zone 1, if you look at their life expectancy compared to St. Johns County in the suburbs, right, where more money is, where it's a higher socioeconomic status, the life expectancy between those two environments is much different. What you also have to take into account, especially in Jacksonville in the urban core, is crime. Crime plays a big part in the negative health effects of communities. And this is what I had talked about before. So, I mean, if you sit back and take a look at it, common sense really tells you that we really need to spend more money on population health policies to be able to prevent chronic disease and to be able to prevent determinants or detriments of health, right? And a lot of countries on the in the United States that have a much lower per capita health expenditure than the United States, you'll see that their percentage of their budgets and what they spend on population health and prevention and disease prevention in their countries is much, much more. It's a bigger slice of pie than what we spend in the U.S. Okay? So the U.S. is really inverted on what we need to do. And if you look at it, right, there are a lot of factors that cause, and I said in the beginning of the class, the U.S. healthcare system has 3 big issues with it, right? Cost, quality, and access. And so if you look at cost, right, a big issue with cost is that we spend too much money on this medical model to where we're treating disease instead of preventing disease. And physicians and how we pay doctors and hospitals, right, they have no incentive to be able to prevent disease. All the incentive is treating it, right? Fee for service. Somebody gets sick, somebody comes to the doctor to see you, doctor does 15, 20 different services, he's going to get paid for all 15, 20 of those services. Doctors don't get paid if somebody stays healthy. They get paid if somebody is sick and comes to visit the doctor. And so that's got to be a fundamental shift if we're going to start preventing and getting rid of some of the $3 trillion costs that we had in the healthcare system. We have to change how we pay providers. If we're going to start switching away from a medical model, we have to go more to a population health model to be able to prevent disease, right? But again, that's just one of the fundamental flaws of the United States healthcare system. There's some discussion questions. Again, the textbook, this chapter is literally like 15 pages. It's pretty easy to follow. Email me if you have any questions.